Hello, this is Dr. Bratzler, and I'm going to go ahead and give part 2 of Chapter 11 discussion of health insurance and healthcare systems. I'm going to include some information that wasn't in the textbook, but I think it's important that you have some of the most up-to-date information as you start thinking about health insurance in the United States. So these are the learning objectives. We reviewed them on the last session. Today I'm going to spend a little bit more time talking about some of the projections for cost of care, and in particular I'm going to spend some time talking about some of the new payment models that are being developed to try to avoid some of the overuse of medical services that don't provide particular help to patients. So, how does the United States compare to other developed countries in the world with respect to healthcare services? And as we briefly discussed last time, it's not particularly good. This is a slide that looks at all of the developed countries of the world. It's OECD data, and you can see in your textbook there's a comparison of the U.S. healthcare system to both Canada and the United Kingdom, and there are two things that are quite apparent on this particular slide. Number one, the United States is clearly the outlier with respect to total expenditures, healthcare expenditures per capita. I think last week, in the last presentation, I talked about that the United States is now at more than $11,000 per every person in the United States to deliver healthcare services. Look at the UK and Canada that are down around $4,000. This is 2015 dollars. Secondly, you can see that life expectancy is higher in virtually all of these other industrialized nations like Japan, Norway, Canada, UK, and others than in the United States. There was a recent poll that looked at healthcare systems in the world and ranked the United States 37th, just behind Costa Rica in terms of health outcomes. So we don't look particularly good compared to other Western countries. This is a study from the Commonwealth Fund. It's a bit more up to date than the one that's in your textbook, but this is the overall ranking of the United States as compared to other modern countries, and you can see that for the most part, except for care processes, the United States did not look particularly good, ranked dead last as compared to all of the other countries. And we were last with respect to access to care. That's because we have a large number of uninsured people in our country still, and it's very difficult to get in to see a primary care physician because, as we'll talk about later, we don't have enough primary care physicians. We're also last in terms of equity of care and health outcomes. So really not a very good picture of U.S. healthcare and the system as compared to other countries. Again, similar data showing that when you look at these 11 different countries, the United States performed dead last in terms of overall performance on health outcomes, despite the fact that we spend more money than any of those other countries on healthcare. So these are some of the points that were made in the book, just to highlight a couple of things. Number one, we have a very, very expensive healthcare system in the United States, as we talked about in the last lecture, approximately 18% of the gross domestic product. We have a very fragmented health coverage with government and employment-based coverage. Believe me, be in a physician's office and try to work your way through the quagmire of all of the different forms that you have to fill out. Each insurance company may have their own formulary of medications that you have to use. They all have different paperwork. It's really, truly a quagmire. The administrative overhead is substantial in the U.S. healthcare system. U.S. healthcare system is incredibly heavily specialty-based. Only about 1/3 of our physicians go into primary care, and that's because they don't make nearly as much money as specialists do, which is very different in other countries, as I'll discuss in a moment. So we're heavily specialty based. We're also very technical based. which means that we do a lot of tests, procedures, and other things that drive up the cost of health care. We have huge fragmentation. One of the newer issues that's happened in the United States is the growth of the hospitalist movement. These are doctors that just take care of patients in the hospital, and there are good studies that show that they're pretty efficient at hospital care because they understand the hospital programs. However, they don't know the patient at all. So certainly in the early years of my practice, when I was taking care of a patient in the office, if they needed to be hospitalized, then I admitted them and I took care of them in the hospital. I knew their history, I knew their family, I knew everything about the patient and could avoid reduplication of testing and other things because I knew what had already been done. That's not the case now. Hospitalists often take care of the patients in the hospital. They may have, they work shifts typically, so a patient may have multiple hospitalists that see them during a hospital stay, and what it's done is increased fragmentation of healthcare for patients that are in the hospital. We already mentioned in the last lecture, we still have about 10% of our population that is uninsured. That's better than before the Affordable Care Act, but the rate of uninsurance now has been creeping slowly back up as different provisions of the Affordable Care Act have been reversed. Certainly, if a patient has good insurance, they have better access to care. There are many practitioners that simply don't accept payment from programs like Medicaid or others and will only see patients who have private health insurance. And then, as I'm going to show you in a little bit, the United States has extremely high administrative cost of care. So this is an article that was published by Glenn Hackbarth and Don Berwick in the Journal of the American Medical Association a few years ago that looked at wedges of waste. They predict from their studies that anywhere from 25 to 30% of every single dollar spent on healthcare in the United States is wasted. Doesn't help patients. It is simple waste. And so they looked at what those different categories of waste were. And there are things like fraud and abuse, which obviously is illegal. Pricing failures. We actually see less use of hospitals today than we used to, but prices in hospitals have continued to go up to meet that difference in overall usage. We've mentioned a couple of times now administrative complexity, not only in the physician's office, but also for the patients, and administrative complexity on the side of the insurance companies. Overtreatment, we mentioned before that because we've had principally a fee-for-service payment system in the United States, it encourages people to do more stuff because you get paid more if you do more. Certainly failures of care coordination. One of the big problems that we still have in the United States is high readmission rates and then failures of care delivery. So we're seeing large amounts of waste, with approximately 1/3 of all U.S. healthcare spending is waste. Contrast that with Canada, which has a national policy to keep expenditures less than 10% of the gross domestic product through a combination of taxes and insurance. They have government insurance for basic health care, so they essentially have universal coverage. Everybody gets basic coverage. They have a different mix of primary care physicians and specialists, with about a 50-50 mix. The other thing that Canada does very well is they control capital purchases of high-tech equipment, so they regulate that. And of course, the stories that you always hear from Canada is that certain procedures and other things are delayed. Though I have to tell you, I've lectured at a variety of Canadian conferences and hospitals, and in general, I find that people love their healthcare system very much, and they have much, much lower administrative costs because, in general, the government is controlling most of the expenditures. There is some private insurance in Canada, which does allow people to have different types of healthcare in the country. Compare that to the United Kingdom, which is often touted as one of the best healthcare systems in the world. They actually budget their healthcare system at about 8% of gross domestic product. They control it. They have universal health coverage, so every citizen is covered, has health insurance through the National Health Service. There is an option for private insurance if you want additional coverage for other things like dental work or other things, but your basic healthcare needs are covered completely. It's a single payer, so there's no negotiation. There's capitation, meaning that the providers are paid a flat amount of money per member per month to take care of a group of patients, so you're not incented to do more stuff to the patient. You get paid a per member per month payment whether you see that patient 10 times in a year or 1 time a year. Most of their specialists are salaried, so that helps to control cost. And again, if you have salaried specialists, then there's no incentive to do additional testing or other procedures that aren't warranted. Now, I will tell you that there is a private health insurance market in the UK, and some patients with means actually do buy that, and some specialists can then enhance their income through private insurance. They're very heavily primary care, 2/3 versus 1/3 specialists. Hospitals are typically owned by the government. They have global budgeting, so they set an overall budget with a limit on national expenditures, and they live within their means, and they have much, much lower administrative costs than the United States. So, what can we do in the United States to control the cost of healthcare? Well, what's driving those increasing costs? And I would tell you that this is a simplistic list. It's from your textbook. Aging the population, I'll show you in just a moment, aging actually probably isn't a huge contributor to the overall cost of care in the United States, though one thing I will point out is that a lot of people live into old age with multiple chronic diseases. That is different. So the example I use is that when I was first in practice, before we were doing angioplasty, before we had started doing clot-busting drugs for a heart attack, guess what? A lot of patients died after their heart attack. And now the mortality rate, the survival rate from a heart attack today is much, much higher, and many of those patients do very well. However, they may have heart damage and they may develop chronic heart failure. So what we have is a bigger proportion of the patients who might have died in the past because we weren't able to open up those blocked arteries before, but now they live into perpetuity with diabetes, chronic disease, and other conditions that are becoming much more common as the population ages are things like arthritis and other forms of vascular disease. Technical innovations, I've already highlighted this. There are tons of new technology that are developed that provide very, very incremental improvements in patient outcomes, if at all, but are very, very expensive. So the one example that's been incredibly controversial is the use of proton therapy. You hear them advertised all the time. There actually is very little published medical evidence that proton therapy is any better than traditional radiation therapy. Yes, it does target the beam of radiation much narrower than just traditional radiation therapy, but it actually doesn't seem to do much to improve patient outcomes, with a few exceptions. It's very, very good, for instance, in children with brain tumors, where we don't want to do any damage to the tissue around the tumor. So we use proton therapy routinely for kids with brain cancer. But for the most part, just recognize we have these technical innovations. They're very expensive, and they don't often provide additional patient benefit. And then the other thing is patients can shop around and get pretty much anything done they want. So if I see a patient and they want some service, and I try to convince them, through some medical science, that the test or the procedure actually won't help them much, they just go to somebody else and find somebody that will give them what they want. The success of medical care in the United States has raised expectations and rapid access, particularly if the patient wants something done that is procedurally based. They can almost always find somebody that's willing to do it. The one example I have that's very, very contemporary is the use of the arthritis lupus drug called Plaquenil, the malaria drug for COVID-19, the current one. I've had patients call me and say, you know, doc, I need you to call the pharmacist and tell them I have this so that they'll give me a prescription they'll fill my prescription for these drugs. And I asked them, well, why are you taking them? Well, because my primary care physician said I needed it to protect myself from the advancement of this viral infection, even though there's absolutely no published data that has shown any improvement in patient outcomes by using these anti-malarial drugs to treat COVID-19. There are a couple of very, very, very small studies that suggest it might reduce the virus, but no study has shown that it improves patient outcomes. And yet people are out there broadly prescribing this stuff, and because patients have heard it in the news and they've heard the president talking about it, they're going out and finding people that will prescribe it for them. And it's created a problem for those patients that need those drugs, particularly patients with autoimmune disease, where those are the contemporary drugs that we use all the time. Well, here's a little more contemporary data from Health Affairs, looking at what's actually driving the increased cost in healthcare. One thing you'll see is that growth of the population isn't really having much of an impact. If you look at the graphic for 2020 to 2025, age and sex mix of the population, yes, the population is getting older, and we do have a larger proportion of elderly patients, but it's not that big, and that's not what's driving the cost. Use and intensity of services is actually going down. We use fewer hospital services now than we used to because we can treat many, many patients in the outpatient setting. The thing that's driving increased cost, at least in the United States right now, is price. That price may be drugs. You've all heard the stories about very, very exorbitantly priced drugs now. Drugs that used to be pennies, drugs that I used to use that were generic even when I was starting my practice, are now being charged for very, very high because of new indications. Testing, obviously, and then hospitalizations. Hospitalization rates are down, but the overall price to be in the hospital is actually higher. So this is the concept of some of the payment models that are being addressed to try to reduce healthcare spending cost in the United States. And it's this concept of moving away from the old system of healthcare of fee for service, where you got paid more for doing more. In this particular payment model, you move to value, you get paid more for delivering high quality care at the lowest cost. That's what you want. Good quality care, but you want your doctor to do it at the lowest cost possible. So that's the concept of value. So quality and service, or the patient experience divided by cost, equals value. You increase value by improving the quality and the experience of care, and you can also increase value by reducing the overall cost. Again, this concept is that we want to move from getting paid more for doing more to a system that allows you to profit in healthcare by keeping your population of patients healthy, delivering high quality care, and doing so at less cost. So think about it. If you're paid for a population, look at that bar, and look at accountability for population health. If you're paid to keep a population of patients healthy, you will very much try to avoid putting that patient in the hospital. You'll do whatever you can to take care of them in the outpatient setting and to keep them healthy, to keep them out of the hospital. And that's the concept of these new models of payment that reward clinicians for doing things that keep the patient population healthy and out of our most expensive settings of care, like hospitals. So we'll go through just a few of the models that are out there. I'll highlight just a couple of them. In particular, I want to talk about the concept of bundled payments because it's one that I coordinate here at OU, but we have lots of these different payment models. So, addressing the social determinants of care. So the example I use, and I use this often, but there are studies that show that it actually works. When I first came on board as the Chief Quality Officer for OU Physicians, I was looking at quality metrics for our pediatric doctors. And one of the things I noticed was that our children that in our practice with asthma had relatively high rates of use of the emergency room and hospitalization. And so when I first started looking at it, I thought, our doctors aren't doing a very good job. They're not prescribing the best medicines that would keep a kid with asthma from having to go to the emergency room. And so I did a study. I looked at it. I started looking at the use of what we call controller medications in asthma that might keep the patient out of the emergency room. And what I found was our doctors were doing very, very good. They were writing prescriptions for those medicines more than 95% of the time. The doctors were very bright and they were giving the right medications. So why did they keep coming back into the emergency room? Or why did they keep getting admitted? It had nothing to do with what we were treating them with in our clinics. It had everything to do about their circumstances, living circumstances at home. If a kid with asthma lives with a parent that smokes, they're going to be in the emergency room more often. If a kid lives in a home that has mold in the ceilings or in floors, they're going to be in the ER more often. We know that roaches are a known risk factor for asthma. If they have lots of dust mites in their pillow or in their mattress, it increases the risk of being in the hospital. It's the environmental factors where the patient lives that are driving these utilization of services. It's not the pills that we're prescribing or the inhalers. That had nothing to do with it. Now, it's one thing to prescribe the right medicine, but also remember that if a patient can't afford the right medication, then they don't help. So what we started doing with our kids with asthma, we started looking at what were the circumstances that were making those kids come back to the hospital more often. And I will tell you that if you compare the cost of hiring an exterminator to go into a kid's home and kill roaches to the cost of going to the emergency room just once, you can save a lot of money in healthcare by paying for the exterminator. Well, under the old fee-for-service system, that didn't make sense. Because remember, you got paid more for doing more. So if the kid came back into the hospital, you admitted him, you charged daily services in the hospital, you got paid more for taking care of the kid in the hospital. Under accountability for the population's health, the system of moving to profiting by keeping the patient healthy, then it allows us to think about, well, let's take the dollars, those per diem, those capitated dollars that we're getting, and let's buy the kid a new mattress. Or let's send an exterminator to the kid's home to get rid of the roaches, because I know that that will save us money in the long run. It's the concept of addressing the social determinants. So there are many different new payment models that are trying to move us away from the old fee-for-service system. One of them is payment bundling, which I'll talk about in just a moment, but it's the concept of a patient comes into, I'm going to use the example of the heart attack again, patient comes to the hospital with a heart attack. We're held accountable for all costs of that patient during the hospital stay and after they go home for the next 90 days. And we profit if we give high quality care, but we reduce that overall cost for that 90-day episode. It's called a bundle, all the cost of care bundled. Accountable care organizations. This is the example I think I used in class one time before spring break, and that's, you have 5,000 patients. A payer is going to give you $10,000 per patient per year, so you're getting, your $50 million, and you got to take care of those patients, but you have to pay for every bill for that patient. Again, you're incented to deliver high quality care, but to do it at the lowest cost that you can. Concepts of shared savings. That's where if you reduce overall costs, the payer, whether it's a private insurance company, Medicare, or others, gives you part of those savings and they keep part of those savings. So both are rewarded. Concepts of clinically integrated networks and others. So the whole concept here, you don't need to memorize all these models. The concept is that these models reward high quality care at the lowest cost. To reduce that incentive to do more, especially unnecessary care that doesn't add value to the patient. So this is the concept of a bundled payment or an episode. A clinical episode typically will last anywhere from 30 days to 90 days. I'm running a project at OU Medicine, and all of our bundles are 90 days long. Medicare pays OU Medicine a just like they always do. They pay us, fee for service for the care of the patients. But at the end of 90 days, they add up all of the dollars that they paid us, that they paid the laboratory, that they paid for drugs, that they paid for in the rehabilitation center, the skilled nursing facility, hospital charges, doctor charges. They add it all up, and they calculate the target price for that patient based on the patient's age, gender, diagnosis. Once they do that, here's the model. Basically, they set a target price for that patient based on their severity of illness, their diagnosis, age, and other factors. If at the end of that 90-day period, we spent more than that target price, and when I say spent more, what I mean is that Medicare paid us more than that target price, we have to pay it back. However, if we reduce the overall cost of that 90-day period of time, we get to keep the extra, the shared savings. So that's the concept of episode-based care. You look at all services for a patient for a diagnosis over a period of time, in this example, 90 days, you're held accountable as a hospital or as a physician for all of those costs. The way you profit is to meet all the quality metrics, but reducing the overall spending on the patient. Accountable care organizations, another one where groups of providers across different settings, primary care and specialty, including hospitals and clinics, come together to share joint responsibility for the overall quality and cost of care for a large patient population. So this is the example of, you get assigned 5,000 patients, they pay you kind of a global budget, and then you have to manage those patients. And when you do that, you quickly figure out that if you poorly coordinate care, if you do redundant test overlapping care, if you don't coordinate things, you lose money. So you have to deliver high quality care and look at the usefulness of everything that's being done for the patient. Reference pricing is the one that I like to highlight because it's very effective at reducing healthcare spending. So let's pretend that every state employee in Oklahoma is under a reference pricing program for certain services that they can receive. So I'm going to use the example of a colonoscopy. So colonoscopy is where a physician puts a endoscope into the rectum and does a complete examination of the colon looking for colon cancer. It's highly recommended. All patients at age 50 and above should be screened for colorectal cancer. Well, it's been shown multiple times before that if you look at all the different healthcare systems, the doctors that do colonoscopy, the charge for that particular procedure varies hugely between facilities. So what happens in this circumstance, let's say again it's the state of Oklahoma, and they kind of look at this and say, why does OU Medicine charge 3 times as much as Mercy, or why does Integris charge 3 times as much as our GI physicians in an outpatient setting? They look at that, they look at what it seems reasonable to cover the cost of that procedure, and they set what they call a reference price, which you either accept or not. But here's the thing. So Dale Bratzler sees a patient in the office that needs a colonoscopy. They just turned 50. I want to screen them for colorectal cancer. I send them to a place that has very high costs. Well, what happens is the state insurance plan calls that person and says, you can go where Dr. Bratzler referred you if you want, but here's how much you're going to have to pay out of pocket because it's above our reference price. However, if you come over here to Outpatient GI Center, who's agreed to our reference price, you can go there, get the same test done, and you won't pay 1 cent out of pocket. Guess what patients do? It's been highly effective at driving patients to go to providers for which they will have no out-of-pocket cost. It's a very effective strategy. It's called reference pricing. Again, the payer, whoever the payer is, whether it's an insurance company, government, an employer, looks at the community, figures out what an appropriate charge for the procedure is, and that's the limit. That's how much they'll pay for it. You as a patient, if you want to go to a more expensive place, more power to you, you can, but you have to pay the difference out of pocket. Well, there are a number of issues that continue to drive our national discussion of healthcare expenditure. One you've probably heard about a lot in the news, and that's surprise medical bills. So here's an example. You are out skateboarding and break your leg, and you have health insurance, and OU Medical Center is your provider of choice. It's who you signed up for. It's who your health insurance is for. So you show up in the emergency room. They realize you have a compound broken leg. You need to go to surgery to get a plate or something put in. So you get admitted to the hospital for a couple of days. An orthopedic surgeon takes care of you, plates the leg, and you're dismissed. Then you go home. Now all of a sudden, and you assume your bills are covered because you went to your network provider. Well, all of a sudden you get a bill from an anesthesiologist that did your anesthesia for the orthopedic surgery. And that anesthesiologist is a contract employee of the hospital, and their group, that particular anesthesia group, is not a member of your preferred plan. And so you get this huge bill from the anesthesiologist for the anesthesia they administer because it was not, it was considered out of network for your health insurance plan. It happens a lot. Lots of hospitals have contracted physicians that may or may not be a part of the health plan that your insurance company has contracted with. And in this particular slide, you see that up to a fourth of all heart attack patients will get some surprise medical bill from some service that wasn't a part of the plan, that it was out of network. So it's a huge national debate. It's actually very supported bipartisan to fix it, but what's not going well is figuring out how to fix it. Another thing that you have to be aware of is that the cost of health insurance in the United States is growing very rapidly. This particular slide shows that for family coverage in 1999, you could buy a policy for your family for about $5,791 a year. Today, the same policy in 2019 would be $20,576. Health insurance premiums have gone up dramatically because health prices have gone up dramatically. So it's really expensive and becoming much, much more difficult for employers to provide employment-based health insurance and for people to buy health insurance, particularly if they don't have employment-based health coverage. Where do the dollars come from that your employer pays to the insurance company? Well, honestly, it comes from your wages. So instead of giving you salary increases, they're having to pay more money to buy health insurance for you. So it's a huge driver of some of the national discussion about health. This slide shows essentially the same thing, that the cost of family coverage, depending on what type of plan you're in, may vary a little bit, but it's up in the $20,000 range now per year for family health care coverage. But this is the straw that I believe will break the camel's back. So this slide is complicated, but it basically shows a variety of things. So I don't know if I have no idea if the pointer will show up, but if you look at the light blue line, that's wages from 2005 through 2014. Those wages have gone up on average 2% per year. So if you've been employed over that time frame, unless you got a big job title change or something else, on average, your salary would go up about 2% per year. However, look what's happened to the cost of deductibles and co-insurance. there's this hugely widening gap between your wage and how much you have to pay out of pocket for health care. In other words, a bigger chunk of your wage you now have to take to pay for your coinsurance or deductibles. This is impacting every American, rich and poor, middle class. I believe eventually this hugely widening gap between the healthcare coverage you get, your salary that you're paid, and the amount of copays and deductibles that you have to pay will eventually be, the problem that requires Congress to finally act on figuring out ways to effectively modify the healthcare payment system to reduce overall cost of care. Well, in fact, a poll done by the Kaiser Family Foundation and the LA Times showed that 66% of those patients who have an employer-based health plan with high deductibles say they wouldn't be able to pay their bills if they had a major healthcare event. It would potentially put them into debt or even into bankruptcy. So it's a huge problem, one that's growing and one that is not going to go away anytime soon unless we move to some different system of payment for healthcare. Finally, I want to talk about cost shifting. When a patient comes into OU Medical Center and is uninsured, who pays for that patient? Do we pay the doctors, nurses, and the respiratory therapists, the technicians, and others that take care of the patient? Of course we do. We feed them, we take care of them, we provide the test. So how does their care get paid for? Well, it's paid for by you. It's called cost shifting. We just shift the cost of those who are uninsured to those that are insured. And so it's been shown in some studies that up to $1,000 per year of your coverage goes to pay for the cost of care for the uninsured. We cost shift. We have universal health care. It's just you're paying for it with your private insurance. So it's basically the practice by a hospital of charging more to one group of patients because another group isn't paying its share. So it's a well-known problem. Again, the health expenditures get paid by somebody, and that's why you hear these stories about the patient got a bill and their one Tylenol pill was $250 or something like that. It's because of cost shifting. It's to cover the cost of those patients who have insufficient means, underinsured or uninsured. So that's the challenge that I'm hoping all of you, as you go out into your careers, can help us fix. We have to find out a different way, I believe, of financing healthcare in the United States because the current system is broken and frankly, it's not sustainable. We can't get, I saw a news article this morning that by 2028 we would be at 20% of the gross domestic product on healthcare spending, and frankly, that increasing percentage of the gross domestic product spent on healthcare is not sustainable. So let me go back to the story I started with, Jesus and Olivia. I just want to highlight, remember Jesus had recently had a stroke, still had some residual, has hypertension and high lipids. This is old data. I really struggled to find some recent data, but the lifetime cost of a person with a first stroke in 1990, a long time ago, 30 years ago, was $100,000 averaged across stroke types. It's probably $300,000, $400,000, maybe $500,000 now. So think about it. A patient who is uninsured, which would we rather pay for? Would we rather pay for preventive services in the ambulatory setting, or do we want to get stuck with $500,000 in bills over the rest of the person's life? It's this ongoing problem we have about having some people with insurance and those without, because again, if Jesus ends up in the hospital in the future and he's uninsured, which he is, you're going to pay his bills, whether you like it or not. Olivia's a little different. She had diabetes. Diabetes is known to reduce life expectancy, but even with that, the expense for her care going forward would be anywhere between, be in the neighborhood of $200,000. despite a reduced life expectancy. And again, older dollars, so probably much higher than that now. The point is that we live in a system that allows people to be uninsured and not get basic healthcare services. And so we shift the cost of those patients to others because they don't have coverage. We cannot, remember by law, you cannot deny coverage to these patients. If they show up in the emergency room, you're required by law to provide services to the patient. So I love this old quote by Hubert Humphrey. It's actually on the wall in the Washington, D.C. HHS building. And it basically says the moral test of a government is how that government treats those who are in the dawn of life, the children, those who are in the twilight of life, the elderly, and those who are in the shadows of life, the sick, the needy, and the handicapped. And I'm just telling you, I hope that all of you as future healthcare leaders in your public health careers can help us fix this problem, because we're not doing a very good job at most of these moral tests anymore. Next week, I'll check with Dr. Raskob, but I may set up a short Zoom session if people want to just chat about some of these concepts and have any questions. Thanks.